Okay, I think we can start now. So good evening, everyone. My name is Nandini Batta. I'm an education officer at UIMS. I'm currently studying in the fourth year at the First Faculty of Medicine in Prague, Czech Republic. And I warmly welcome you to the second lecture in our radiology series, which we are organizing in collaboration with Pleven University's Emergency Medicine Society. Today's lecture will be presented by Dr. Karthik Rajagopal. Just a few words on the organization of the seminar. I request all the viewers to please keep their cameras off during the lecture as we are recording this, and it will be put up on our social media sites. We request you to please ask any questions at the end of the seminar or put them down in the chat for the speaker to address them in the end. The participation certificates for this event will be provided to everyone attending today at the end of the seminar. That's all from me. Dr. Karthik, I request you to please share your screen and begin the lecture for us. Thank you.
Thanks, Nandini. I'm Dr. Karthik, and one of the A&E doctors at Croydon University Hospital. Been working as a doctor for the last 4 years, and this is our presentation. So we're going to do an introduction to chest X-rays and abdominal X-rays, and what the key signs to look for in both of them. So first, let's go with chest X-rays. So what are the most important presentations for chest X-rays? What are we looking for? If you could type in the comments, guys, and let me know what you think, and then I'll get to it.
Could you repeat the question, please?
I said, what was the most common presentations we see on chest X-rays and abdominal X-rays? Oh, a few good guesses. Okay, so for chest X-rays, we're looking at pneumonia, pneumothorax, we're looking at NG tube placements, various things. For abdominal X-rays, I think the use of abdominal X-rays have become limited in this generation because of the availability of CT scans. And actually, abdominal X-rays are about 7 to 10 times the radiation of a normal chest X-ray. So typically, especially in the emergency setting, we only really take chest X-rays. If we're querying a surgical emergency, we typically go for CT scan straight away. But if the CT scan isn't available straight away, that's when we opt to do abdominal X-rays to rule out things like small bowel obstructions, foreign body ingestion, and things like that. So let's go over the basic anatomy of chest X-rays. Give me a second. Yeah. So there's 12 total ribs on the chest X-ray, and to get a proper chest X-ray, we need to see at least the first 1 to 10 ribs, just to make sure that we get a proper viewing of everything that's going on. And normally, if we don't get that, we typically ask for the X-ray to be repeated. Okay. So things to look out for in the chest X-ray. So immediately when you first look at a chest X-ray, you'll see different colors. So what do all of these colors mean? So I put in here about 4 colors, but there's actually a 5th color. So firstly, the black zones are normally air and gas, so less dense. And the dark gray is fat, and the light gray soft tissue and fluid. So typically our organs, intra-abdominal organs, we'll see in this sort of light gray structure. The white is what we see, the bone calcifications, and I haven't written it here, but the intense white is basically metals and things like that. So I think like batteries. So sometimes we find kids ingesting button batteries, even adults too, and they come up as a very intense white color. Okay, so these are the different views. I don't know if you can properly see it, but we have the AP view, the PA view, and the lateral view. This is of chest X-rays. So as you can see, the film and cassette on the PA view, the body, the chest is placed firmly on that plate, and that's a PA view because the film is projecting onto the back of the person, of the individual. And I'll explain why we actually do those for chest X-rays and why it's actually preferred. So firstly, when we're doing a normal chest x-ray, so this is a erect chest x-ray where the patient is standing up. It's a PA view, meaning that again, the chest of the patient is on the film plate, and they're about 6 feet away from the x-ray tube. And this is so we get a proper ratio of all the anatomical structures within the thorax. So the difference between a PA view and an AP view, and why we actually prefer PA view. So as you can see here, I don't know if you can see my arrow, guys, but in the AP view, we see the scapula, and this sort of distorts the image slightly. Whereas on the PA view, we don't see the scapula as much as outside of the lung field, and we get a more expanded chest. So if you can see here, the length of that compared to here, we get more expansion on the PA view. And this is why we typically opt for PA views in the emergency setting. Okay, so now I think the most important thing, rather than jumping to emergency presentations, I wanted to go through the actual anatomy. So I think the most important, well, there's all of the structures are important, but when identifying different emergency presentations, the main things we look for in terms of rib fractures, obviously we're looking at the ribs. So labeled in yellow are all the posterior ribs, and labeled in blue are all the anterior ribs. You have obviously the pulmonary artery, the right and left hilum. You have the trachea. Trachea we need to look for, and like for example, we're querying tension pneumothorax, we have tracheal deviation and deviation of the other mediastinal structures. So this is the costophrenic angle. So here we see, I guess, almost complete loss of the costophrenic angle when there's a pleural effusion. Obviously, this is normal, but in a pleural effusion, for example, this angle that you're seeing here will be completely lost and we won't be able to see it. So here we have the right and left hemidiaphragm, the liver here, and on this side we'd have the spleen. Okay. So if you want a systematic approach on how to read a chest x-ray, I think this diagram best describes how to do it. So typically, so just so that you don't miss anything, we normally go airway, breathing, circulation, and diaphragm, and we look at the individual structures and approach the chest x-ray in a systematic order. Okay, so as we were talking about earlier, these are the key presentations and uses for chest x-ray. So rib fractures, flail chest, pneumonia, pleural effusion, pneumothorax, pneumoperitoneum, which we sometimes actually look for in abdominal x-rays, but I think chest x-rays are the more common use for it now. NG tube placement, but again, we normally need a chest x-ray and an abdominal x-ray for this. So where do rib fractures normally occur? What is flail chest, and what is the management of both? If you guys would like to type in the chat, if you know any of the answers of those 3 questions. It's okay, just take a stab in the dark if you need to. Okay, I'll give it another 30 seconds. I think you guys are a bit scared. Perfect. Yep, that's correct. So rib fractures normally occur in the middle ribs. That's because when you experience a road traffic accident or any trauma, it's typically the area that's most affected is the middle ribs. What is flail chest? I think one of you actually commented the correct answer. Flail chest is when the ribs are broken into 2 or more areas. Perfect, yeah. And when basically the breathing is completely interrupted, and you can see asymmetrical thoracic exertions as well. So what's the management of rib fractures and flail chests? So the main thing to realize is that Rib fractures typically will find patients coming to A&E all the time with rib fractures, and they're often shocked as to why we don't actually surgically, if it's not a flail chest, why we don't actually operate them. Because typically, to actually operate on the rib fracture or on the rib fractures, there's more risk involved than actually good to repair those rib fractures. And typically, if it's only 2 or 3 rib fractures, they can normally heal on its own quite well. Okay, so this is just an illustration of some rib fractures. Okay, so these are some old rib fractures. So as I was telling you earlier, sometimes we just let them heal on its own. And if you look at it very carefully, they're starting to heal, but they're not exactly aligned correctly. And sometimes this becomes a more permanent issue and they don't always align perfectly. Okay, so pneumonia. This is another, I think, the most common presentation in A&E. So what we're looking for in a chest X-ray with regards to pneumonia are white spots or patchiness. So you can see here in this normal X-ray, you're seeing it's quite clear. You can see the lung markings. It's quite clear. But here you'll see these white spots and infiltrations and patchiness. This is a COVID-19 chest X-ray. Treatment for the pneumonia, of course, is dependent on causative organism. I think typically we in A&E treat, I think the guidelines now are doxycycline and colmoxiclav. And with COVID, it's just supportive treatment, depending on the day of presentation. So how many days they've had COVID for. Okay, so pleural effusion. So this is what we were talking about earlier. Let's get to the specific signs. Okay. So these are really the 4 main signs that we'll see in pleural effusion, the 4 main things to look for. So here are these light blue segments. You're seeing the opacities on both sides. Basically, instead of the normal structure, let me go back, like here, for example, you're seeing the opacities here. Well, let's use this X-ray. We're seeing opacities here and here, indicating pleural effusion. We also here, we have blunting of or complete disappearance of the costophrenic angle here, indicating a pleural effusion. Here is what we call the silhouette sign, where the normal anatomical borders we can no longer see, so we can't see the hemidiaphragm clearly, the cardiac borders properly. And the final, I guess, sign is the meniscus line here that we talked about in the first lecture. Okay, so what is a pneumothorax? A pneumothorax is a normal collection of air in the pleural space, essentially leading to a partially or complete collapsed lung. And as you can see here, you have these lung markings here, but you have absence of lung markings there. Okay, so what are the different types of pneumothorax and how they're caused? So you have various types. So a tension pneumothorax is much worse than a normal pneumothorax because there's only a one-way valve, which means that air is only entering in one direction. And due to the intense pressure in a tension pneumothorax, hence the name, you'll get a deviation or shift of mediastinal structures. This can be quite dangerous if not dealt with correctly. Causes of pneumothorax, sometimes spontaneous and sometimes traumatic. Spontaneous can be split into 2 categories, and traumatic is things like blunt trauma and things like that. Whereas spontaneous can, even in a completely well person, can happen completely normally and spontaneously. Okay. So tension pneumothorax, this is the main signs I want you to look out for. So hemidiaphragm depression, as you can see here. And here you see what we're discussing in the other image. So asymmetric hemithorax with hyperexpansion and widened intercostal spaces. And here This is the mediastinal shift that we were talking about. So contralateral mediastinal shift. Okay, so pneumoperitoneum typically would need an abdominal X-ray and chest X-ray to identify this, but normally we'd get a chest X-ray, and rather than doing an abdominal X-ray, we go straight to CT if it's readily available, but sometimes we obviously get the abdominal X-ray as well. There's 9 main causes of pneumoperitoneum, and I think the best way to remember them is going A to G, and then there's 2 P's. So it's appendicitis, bowel ischemia, colitis, diverticulitis, endoscopic complications. So that's complications from endoscopic procedures. There's also foreign body ingestion after GI surgery, penetrating blunt trauma, or peptic ulcer disease. And as you can see here, see some free air under the diaphragm. Okay. So as we talked about earlier, when do we use abdominal X-rays and what's the radiation? So as I said earlier, abdominal X-ray is 7 to 10 times the radiation with normal chest X-ray. Limited diagnostic use compared to previous years because of the availability of CTs. I'd see in my department in A&E, there's compared to like 15, I'd say 10 years ago, we did a study, an audit actually, of the amount of CT scans ordered in the last 5 years compared to in the last 10 years. And there was a stark difference. There's, I think, more than 4 to 5 times the amount of CTs that we get. I think it's more nowadays, if we have the CT available, it's just way more safer to get the CT rather than relying on clinical findings and an abdominal X-ray to diagnose a possibly dangerous surgical complication. Such as appendicitis, bowel obstruction, because even in abdominal X-rays, even though one of the main uses is for bowel obstruction, we can't always see it on a plain abdominal film. Obviously, we rely on the clinical findings and the history, so we will have a tense abdomen, or they haven't passed stool for a couple of days, haven't passed any gas. So it's a combination of the history, abdominal X-ray, and then we get the CT based on those 2 things. Okay. So I think this is an important thing to note, is that the abdominal X-ray usually starts from the diaphragm and goes down to the inferior pubic rami. This is so that obstructing inguinal hernia is less likely to be missed. So we're not always going to expect you to see an obstructing inguinal hernia on a X-ray, but this is one of the reasons why we go all the way down to the inferior pubic rami. And we also can see the hip prosthesis on a normal erect abdominal X-ray. Okay, so as we were discussing earlier, the main reasons to take abdominal X-ray: tubal line placements, so like an IMG tube, usually done in combination with a chest X-ray; fecal overloading, but I think to expose somebody to 7 to 10 times the radiation of a chest X-ray just to tell them that they're constipated isn't really probably the right way to go about things. But some people do use abdominal X-rays for fecal overloading. Okay, bowel obstruction and foreign body ingestion. So like we were talking about earlier, kids can swallow button batteries and all sorts of things really. Okay, so this is a barium swallow abdominal X-ray, and I'm going to go through the main structures of what to look out for. And I think this is basically the large bowel, and it shows us, you won't obviously see it this clearly on a normal abdominal film, but to show you the structures, I wanted to use this diagram. So let me get the arrow here. So number 1 here, we have the appendix. We have the ascending colon, the hepatic flexure, transverse colon, the splenic flexure, the descending colon, the sigmoid, and the rectum. So this is obviously the large bowel. difference between the large bowel and small bowel on an abdominal X-ray and where to look for them. So as you can see here, the large bowel is on the periphery of the abdominal X-ray, whereas the small bowel will be centrally located in this region. So the large bowel has folds. They both have mucosal folds, but the large bowel has folds called haustra and usually quite thick, whereas the small bowel has relatively thin mucosal folds. Okay. This is probably one of the most important rules for in evaluating abdominal X-ray. It's called the 369 rule. So as you can see here, centrally located small bowel, and when we're looking at X-rays on the computer, we can actually measure with an electronic tool the diameter or width to see the dilation of the bowel itself. Here was the cecum. So we're looking for 9 centimeters. So this part here, number 2. Okay. And here, the rest of the colon, 6 centimeters, and the small bowel, 3 centimeters. Okay, so why aren't abdominal X-rays used to differentiate between solid organs? So as we saw in one of the first slides, all the organs are typically a light grey color, light to dark grey color. And so it becomes difficult because you'll find a lot of light dark grey structures in abdominal X-rays. So they start to overlap and it's hard to differentiate between the different organs. So typically, if we're querying some pathology in one of the organs, we need a CT scan or at least an ultrasound, depending on which organ we were looking at. Okay, so what signs do we look for on abdominal X-rays? So we have the Wriggler sign, thumb printing sign, the coffee bean sign, string of pearl sign. We actually have hundreds of other signs, but you'll get bored just trying to go through all of them. If you wanted to know, there's football sign, the cupola sign, the triangle signs, various signs to go through. But we'll go through them one by one. Okay, so what's the difference between mechanical intestinal obstruction and ileus? So mechanical obstruction is normally caused by a physical obstruction, typically a mass or adhesions after surgery, tumors, volvulus interception, whereas ileus is caused by, it's normally not the main reason why somebody comes to the hospital. So it could be gastroenteritis that causes it, certain medication, systemic inflammation that will lead to reduced peristalsis. Okay, so this is why this is different views on small bowel obstruction. So normally it's not always this clear to see a small bowel obstruction, hence why we use CTs. But as you can see here, so the first thing to notice is that it's centrally located, so we know it's not the large bowel on both views. And we can see if we measured it, it'd be greater than 3 centimeters. Okay, so the string of pearl sign is also a sign of small bowel obstruction. Basically, if you can see it here and here, it's basically due to the different fluid tension levels that cause that formation. But yeah, we see it actually every now and then. Okay, so this is probably the most common type of volvulus. So volvulus basically means twisting of the bowel. And you get this coffee bean shape here that sigmoid volvulus is famous for. Here you have the cecal volvulus, so where you see absence of colon in this area. Here you have haustra present, but here you don't. Perfect. So other things that we use that can be identified on an X-ray is kidney stones. So like we said earlier, bone or calcifications, which is essentially what stones are. appear very white and dense due to their density. So here is you can see staghorn calculi. You can also see kidney stones, gallstones on X-rays as well. But to identify staghorn calculi, renal stones, or gallstones, really you would need CTs. With renal stones, you'd use CTK UV. Abdominal X-rays are really not the way to diagnose them. Okay, so other foreign bodies that we can see on X-rays are things like a hip prosthesis, so a complete hip replacement here. You can also see hip resurfacing as well. Okay. So going back to staghorn calculi and kidney stones, so what would the treatment of those be? So staghorn calculi, so with normal renal stones, typically we use lithotripsy, trying if the stone is the appropriate size, break them into small pieces with shockwave therapy. With staghorn calculi, you would need something called PCNL because of the size and shape of the calculi itself. Yeah. Another thing, I think typically would get pelvic x-rays for an IUD, but an abdominal x-ray can be very useful as well to see the placement of IUD. See if you can look at this, it forms a proper T shape, centrally located, and that's how you really know it's in the right place. Perfect. So another thing we were talking about earlier is the thumb printing site. That basically is an indication of an infection or inflammation. You don't always see it on abdominal x-rays, but quite nice when you do. Okay, so I've got one more sign to show you guys. So the regular sign. I think you need to go through many images of regular sign to properly understand what it is. But it's essentially a sign of the peritoneum where you can see both sides of the bowel wall. So you'd see lucency on both sides. So you'd see like a dark gray or black on both sides of the lumen, of the wall. But it's something that you need to see, I think, plenty of x-rays to properly see it. That's why I left it as the last slide, because if there's one sign, you probably need to look through a couple of times. It's probably the regular sign. Good. Perfect. And that's the main or key presentation seen on abdominal and chest x-rays. Does anyone have any questions? So I think the question was why I wouldn't recommend abdominal x-rays for bowel obstruction. So typically, realistically speaking, you can't really say that there's a bowel obstruction unless it's a complete obstruction on an abdominal x-ray. You would need a CT because you could easily miss a bowel obstruction on an abdominal x-ray. We see it missed all the time. So that's why you need a CT to actually confirm whether there's a bowel obstruction. But typically, we do abdominal x-rays first because it depends on the history of the patient. So if the history and clinical findings are consistent with bowel obstruction, we'd refer to the surgeons anyway, and they'd still get a CT. But if we're not convinced that it's bowel obstruction based on the history, abdominal x-ray can be used to confirm that it's actually just fecal overloading that's causing all the pain and tenderness in the abdomen. So that's why first line, if you ask me what the first line would be, CT. But realistically speaking, we would go again abdominal x-ray first. It's the same reason why a CTPA is the number one for diagnosing a pulmonary embolism, but we usually get a well score and a D dimer to sort of confirm our diagnosis before getting the CTPA. So the gold standard is a CT abdo-pelvis, and the gold standard for pulmonary embolism would be a CTPA. but that doesn't mean we can't do other things until we get the CT scans, basically. Thanks, Nicole. Anyone else?
There's another question where they're asking what are some common incidental findings of abdominal X-rays?
Oh, I can't see that question. So common incidental findings are really, so you'll see spinal wires from recent or previous spinal surgery. Sometimes if they're wearing a chain or on the back of a bra, like the metal parts of it, sometimes you can see surgical tissues or gauzes that are left post-surgery can sometimes be seen because they're intentionally made radio-opaque. So you could see on an abdominal X-ray. Obviously, you have the IUD, the staghorn calculi, because you wouldn't necessarily use abdominal X-ray to diagnose kidney stones, but you can instantly find it on kidney stones. And sometimes other incidental findings are ingestion of foreign body, like I said, batteries, things like that, really. Anyone else? Okay, perfect. Thank you guys for listening to the presentation. I'm a bit unwell, so wasn't delivered as the best I could, but hopefully the next one will be a lot better. Let me know if you have any questions. You can message the team or message me on Instagram. I don't really mind. Happy to answer all questions. Yeah.
Thank you so much, Dr. Karthik, for organizing this wonderful seminar with us. We really hope you get well soon.
Thank you.
And if there are any more questions, please put them in the chat. I will now share the feedback QR form, and you can fill in the feedback form to get your participation certificate. A minute or so after that, I will stop the recording. So if you're more comfortable asking questions, then please go ahead and do so. I hope everyone can see the screen, so please feel free to scan the QR and send in your feedback and log off so that we know when to end the meeting. Thank you.
Thank you, Dr. Karthik.
Perfect. Thanks, guys.
Thank you, Dr. Karthik.